Well, good afternoon, everyone. This is Donna McKelvey. I am the Vice President of Development and Membership for Research America, and it is my pleasure to welcome you to today's webinar, Innovative Research and the Opioid Epidemic. Are we closer to finding solutions? So before we get started this afternoon, I'd like to just go over a few items so that we can make sure that your participation in today's event is smooth. So first, I wanted to share with you that our webinar is going to be recorded, so it will be available for playback later. And then secondly, and important, I wanted you to all know that non-speaker lines are going to be muted, but we will be having a portion for Q&A later on. So at that point, to submit a question for the Q&A portion, you're going to click the orange arrow on the webinar's control panel to expand it, and then you type your question in the appropriate box. You may submit questions throughout the briefing in the chat box function, but we will be saving, again, all of our Q&A till all of our speakers have had a chance to present this afternoon. So again, just want you to not worry. We will leave plenty of time for questions at the end. And again, I just want to give you a warm welcome to our call today, and thank you for your participation. So I would like to, again, it's my pleasure to just do a very brief introduction to our terrific three speakers for today's webinar. We have Dr. Nora Volkow, who is the Director at the National Institute on Drug Abuse at the National Institutes of Health. We also have Dr. Georges Benjamin, Executive Director, the American Public Health Association, and a board member for Research America. And we also have Dr. Jeffrey Bratberg, Clinical Professor at the University of Rhode Island College of Pharmacy. So we welcome all of our speakers, and Dr. Volkow, I would like to turn it over to you to get us started this afternoon.
Hello, good afternoon, everyone, and I hope that I can figure out how to move these slides. So I still don't have the control of the slide movement. It's not happening. Okay, so and it's not, so can you get the next one, because I don't know why it's not moving, not letting. Okay, so this is where we are and what has led to this recognition that we are in the middle of an opioid crisis. And it's basically illustrated in one of the many measures that we can obtain, but this is the one of fatalities, which obviously is the most dramatic. But it just gives you an idea of how rapidly the number of fatalities and overdoses has increased in the United States from 1999 into 2015. And if you are able to look at the numbers, and the color scale represents the number of overdose fatalities per 100,000 individuals in a population, you can see that in 1999, there were only 2 sites that had red spots, very limited, one in the Appalachian area and the other one in New Mexico. In 2015, we have many areas in the country that actually had rates of overdose fatalities that are over 30, over 100,000. Some of them even have 40 over 100,000. So this has led to the recognition that actually we need to understand, first of all, what's happening, and in order to revert them, and second, to try to aggressively go after it. And what I'm going to be speaking on is how can science help us take reverse this epidemic on the one hand, but also very importantly prevent it from happening again. Next slide. This illustrates why the nature of the problem. All of the opioid drugs that are used for the treatment of pain act by binding to the mu-opioid receptors, and what you see is an area, a 3D rendering of the brain where you see the location of the mu-opioid receptor. And the color scale is, again, the red colors, higher concentration, yellow, green, and blue. And you see that areas that have the blue arrows, all of them reflect areas that are part of the pain network, where are loaded with mu-opioid receptors. And mu-opioid receptors, when they are activated by drugs like morphine, actually inhibit signaling, and that leads to why they are so extraordinarily helpful in dealing with acute pain. Unfortunately, what you see there in a red arrow is that you also have very high concentrations in the nucleus accumbens, which is the main reward region of the brain. And when drugs that bind to these receptors activate this area, it's highly, highly rewarding, and it actually can result in addiction. So where we are is that we have very effective drugs against pain, but at the same time, through the same mechanism, they are activating highly rewarding areas that are that can lead and trigger addiction. And the other aspect about this type of drugs that act through the mu-opioid receptor is that while they are incredibly potent for analgesia, with repeated use, you become tolerant, which means you need higher and higher doses. And the higher doses that you get, the higher the risk for addiction, and the higher doses that you get, the higher the risk of respiratory depression, which is the main cause for death on an overdose. Next slide. This illustrates why we are right now where we are. So you take these very powerful drugs that are incredibly potent acute analgesics, but also highly, highly rewarding and addictive. And at the same time, in the late 90s, beginning of certainly moved towards at the beginning of the 2000s, a very aggressive campaign to improve our treatment of patients suffering from pain. And that led to a massive increase in the number of prescriptions for opioids, and to the misguided perception that if you were giving opioids to individuals that have pain, they would not become addicted, number one. Also misguided perception that you could actually reach very, very high doses of these opioids at greater than 100 milligram morphine equivalent and still be safe, provided that you gave those drugs slowly. But what we have learned in the process is no, you can become addicted to your opioid medication even if you have pain. And also by promoting these overprescription practices, it basically facilitated the diversion of opioid drugs that were then started to be abused for their rewarding effects because of the notion that since they were medications, they could not be as harmful as illicit substances. So it was this very, very significant increase and massive increase of doses of prescription opioids that initiated the opioid crisis and is responsible for the opioid crisis that we're currently living. And in fact, in 2011, just from two types of opioid medication, hydrocodone and oxycodone, there were 219 prescriptions in the United States of these medications. Recognizing this as the origin of the opioid crisis, now there has been over the past 5-6 years a very, very aggressive campaign to try to improve prescription practices of opioids and decrease the number of prescriptions and the number of doses given per prescription. These have actually changed patterns, and what you see to the right slide is that indeed the amount, in this case what you're looking is the milligram morphine equivalent in billions for opioids has gone down from 2010, 2011 into 2015, approximately 15%. And it has continued to go down, and in light of these actually reversal of these trends of very high prescribing practices, the question has been, this should be good news, and we should start to see a decrease in the number of fatalities. The next slide shows where we are with this issue. Have we been able to decrease fatalities? Next slide, please. And what you see is the latest data. It's not the official data from CDC for 2016, but it's the semi-official. It was published on September 12th, in which they are actually reporting the estimated number of fatalities for 2016 based on the states that have reported the 2016 data. And based on this data, what they show is that there's a 22% increase in overdose fatalities from 2015, 22% increase. So not only are we not being able to decrease the number of overdose fatalities, we're actually basically not able to even continue to interfere with a very significant rise in these overdose fatalities. And that, of course, has led to try to see why it is that we are not seeing a positive effect despite of decreases in prescriptions. So the CDC has started to divide those overdose fatalities on the basis of what opioid was responsible for it. And you see that to the right, and you see prescription opioid deaths in 2016 were 14,000. So they more or less, we have not been able to bring them down, but it's sort of stabilizing. But you see on top of it, 15,000 now we have 15,000 overdoses from heroin. And that was something that we have not seen for many, many years, where the number of overdoses and fatalities from heroin was at 2,000. But starting in 2005, we start to see those numbers going up. And now we see a third actor in this opioid crisis, and that's the synthetic opioids, most notable fentanyl. And this is a very potent opioid. It's 50 times more potent than heroin and associated with extremely high rates of fatalities. And this was a drug that from 2012, where you see almost 2,000, it goes to 20,000. A massive increase in the contribution on the number of fatalities. So while we started with a prescription opioid, those patients that became addicted to the prescription opioid, being able to get heroin, which was much more accessible and less expensive, transfer their use into heroin. Heroin comes out now with a very, very high purity, much higher purity than we're used to, and very low cost. The high purity increases the risk of overdoses, and at the same time, the combination of heroin with that is laced with the synthetic opioids increases the fatality rate. And this makes these drugs actually also much easier to bring into the country because they are more potent, but on the other hand, also they are synthetic. So you don't even need to cultivate in order to get these drugs, which are actually quite easy to synthesize. And this is exactly the reason of why we're seeing these massive increases in fatalities and overdoses, despite the fact that we are trying, and somewhat, though still we have a lot to do work on it, containing the number of prescription opioids dispensed. Next slide. So how do we deal with it in terms of science? Well, you see a triangle that is illustrated there on the, with the links on the yellow that identifies on the top the need to actually, in order to address this epidemic, we need to address the need of patients with pain, because there was a good intention to treat them, and we just did not have, first of all, many alternatives on the one hand, and also miseducation about exactly what these opioids will do. And then in the basis, we need to address the need of research that can accelerate the utilization of treatments that we have for people that have become addicted to their opioids, that can help them recover and prevent them from overdoses, but also the need of treatments that can improve our ability to reverse people that are on an overdose so that we prevent them from dying. So the first one is in the science of pain management. Can you get me the next slide? In the management of pain management, basically one of our priorities is what is it that we can do to develop safer opioid analgesics that are also very, very potent. And there are many, many strategies, and some of them are over there. Some of them can we deliver opioids in ways that are safer. And this is an area of science that's fascinating, because it's the idea of being able to tailor an opioid that binds to the receptor in a way that it produces analgesia, but it does not produce the side effects. And while many pharmaceuticals have given up, and scientists, on the possibility of having such a drug, new research that has emerged as on the basis of our understanding of the three-dimensional structure of the mu-opioid receptor has made this feasible. There's also a lot of interest on developing molecules that have analgesic properties that are not based on any of the opioid receptors, and that's an area that's very fascinating. Then you have biologics, which relates to actually the development, for example, of antibodies or antagonists of signaling mechanisms that through the immune system are generating pain. And the beauty of those strategies that in some instances, they may basically, it's not really that they are acting like an analgesia, they are preventing even the pain from happening. And in parallel, we're doing, of course, research that relates to non-medication interventions. Next slide. Next slide, yes. The other aspect, too, becomes very clear is that we need to expand our research on the basic understanding of the neurobiology of pain. And in pain, one of the most challenging concepts is what is the transition of someone having acute pain that then goes into chronic pain, even though the original insult is no longer there. And it is these chronic pain conditions that are the hardest ones to treat and manage in patients, and the ones that have the greatest amount of morbidity to the individual. And for example, we know that, so there's been a lot of interest to try to understand, how do you predict someone going into a chronic pain condition? And now we know, for example, that indeed females are at higher risk of converting from an acute to a chronic state. And the prevalence rate of the chronic pain conditions is higher. For many of them, it's higher for women than it is for men. And this, in turn, is also helping us understand why, too, the epidemic is so inflicting women at such high rates. And one of it relates to the fact, not surprising, women have higher number of prescription of opioids than males. And in the next slide, you can see the translation of this in terms of something that we have never, ever seen. Look at the changing face of heroin use in the United States. It was predominantly a male one in the 60s. Now in the 2010s, we have similar prevalence rates of heroin in males and females. And unfortunately, as you're looking in terms of the fatalities, deaths involving natural and semi-synthetic opioids, the current numbers, what you can see for 2016 is that in terms of females, and you look at the women that are 45 to 64 years of age, we see almost equivalent levels of fatalities in women. And it is these women actually in this age range that are much more likely to be prescribed an opioid medication. So understanding, doing research on pain from epidemiology to neurobiology is very fundamental in terms of trying to do and tailor prevention and treatment interventions. Next slide. The other component that I want to focus a lot on, because it's the one on treatment for opioid use disorder, because we have treatment. We have methadone, full agonist, buprenorphine, partial agonist, and that what that means is even if you occupy all of the receptors, you will not have the same level of effect as methadone or heroin. And finally, you have naltrexone, which is an antagonist, which means it occupies the mu-opioid receptor, but it has no effect. Regardless of the medication that you are used, all of them show that it decreases opioid use, it basically prevents overdose deaths, it decreases criminal activity, it increases infectious disease transmission, it improves social functioning, recovery, retention in treatment, improves outcomes on neonatal abstinence syndrome. So study after study have shown that with large effect sizes. And despite this evidence, these treatments are not being used. And you can ask, well, how bad is it when you say they are not being used? And then you can look at the opioid use disorder cascade of care in the United States and where we are in blue and where we should be in terms of the top line of each one of the bars. Approximately 2.5 million individuals suffering from a severe opioid use disorder, of which, say, 1.6 have been diagnosed. How many are engaged in care? 600,000. How many initiate methadone-assisted treatment? 300,000. How many are retained in treatment for 6 months, which is actually something that you really do require, because if you don't do it, the likelihood of relapse is extraordinarily high. And then those that are in continuous abstinence is less than 2%. So this is the challenge where we currently are in. If we want to prevent overdoses, if we want to prevent recovery, if we want to prevent transitioning to heroin or into synthetic opioid abuse, we need to initiate opioid medication, and we need to sustain the patients in treatment. So how do we do that? Well, one of the strategies, next slide, is to actually develop medications, based on the medications that we know are very effective, create formulations that will make it easier for patients to be compliant, and it will make it also easier for us to reach populations that are difficult to reach because there's no physician or there's no methadone clinic. And like rural communities, where a lot of the problems have arisen in terms of this opioid crisis. So what we are focusing on and incentivizing is the development of long-lasting formulation of these medications. And these are two products that we have partnered with pharmaceuticals in order for them to be successful in delivering these products. The first one is an extended release opioid antagonist, naltrexone, 1 month formulation, Vivitrol, and the right one is a 6-month implantable buprenorphine. In this case, both of them, one of them you just need to go once a month, the other one you need to go once every 6 months in order to get your treatment. So the likelihood of your compliance is much, much greater. And since the greater risk of relapse occurs during the first 6 months, you can see the enormous advantage of having been covered by 6 months. The Vivitrol formulation, we're trying to incentivize other pharmaceuticals or Alchemist itself to extend it to 2 or 3 months. The longer we can cover it, the greater the likelihood that we're going to be protecting these individuals. So this is with respect to the medication development. In parallel, we are working with researchers to develop implementation models that can actually increase the uptake of these medications into healthcare practice. Because we've come to realize that there are not sufficiently specialized treatment programs that can take that can provide treatment for those patients that need it. And in the next slide, you have two examples about how we're trying to do implementation research. One of them, taking advantage of the emergency department, patients go with an overdose. It's an incredible opportunity to initiate a treatment over there, and this is what this study does. It initiates buprenorphine treatment in the emergency department and compares it with patients that are referred to treatment or that are given a brief intervention. And this, what they showed is just this simple intervention of initiating buprenorphine in the emergency department reduces reported use of opioids, increases engagement in treatment, and it decreases the use of inpatient addiction treatment services, and it also decreases the use, in this case, of admission into an emergency department. So very, very simple intervention, and we're now trying to expand it into, instead of just using the regular buprenorphine, use the once-a-month buprenorphine formulation that hopefully will be approved by the FDA next year. To the right is another researcher that we have funded, in which actually these researchers try to address if there is not a place where a patient can go for a treatment, because usually they are overbooked and they tell you come back in 3 months, come back in 6 months, and what happens is within a couple of days the patients have relapsed. So if you cannot admit them then what they said, let's send them home with a device that can dispense buprenorphine in a way that it cannot be tampered with, and that can deliver it in basically with an intervention to ensure that the patients are compliant. And in this study, what you see is that gigantic effect sizes when you have able to go home. In the upper panel, you see the numbers of participants that have remained abstinent. Those that are sent home and says come back in 3 months immediately relapses. You can see that bars are basically there's none of them that have been able to stay abstinent. In contrast, those that were sent home with this buprenorphine delivery system, basically by the end of 3 months, 80% of them were still abstinent. And in fact, highlighting that the ability to be innovative with products. And the last slide, in terms of implementation science, is this one, illustrates the value of having this 1 month, in this case, it's an naltrexone extended formulation, comparing the results. These are parolease and naltrexone versus treatment as usual in the probability of relapse. And you can see significantly higher number of individuals that have not relapsed when they are on naltrexone. And this is a 6-month study. And what's very, very relevant, if you look to your right, is the number of overdoses that were recorded over 78 weeks. And you can see that there were 7 in the control group, the treatment as usual, versus 0 in the Vivitrol naltrexone. Again, highlighting the importance of being able to sustain someone in treatment with medications as a mechanism for them preventing an overdose. And so, yes, we can develop science that relates to medications or to devices, or importantly, to implementation science, and that can help us enormously in terms of improving the outcomes of those individuals suffering from an opioid use disorder. And yet, in my last slide, what I'm basically going to emphasize is, in addition to science, a very, very important component all along. The next slide, please. Is the next slide. Next slide. I'm skipping this. Next slide. Next slide. I wanted to just end my presentation with this slide, because in parallel, what we basically been very, very proactive as part of our dissemination is the recognition that one of the factors that has led to the situation where we currently are is a lack of proper education of those in the healthcare system in 2 areas. One of them is in the area of substance use disorders. So physicians or nurses or pharmacists actually do not have the proper training on screening and intervening or referring for treatment on individuals that have a substance use disorder. So as a treating physician, the physician may be giving an opioid medication, may not even be able to recognize when the patient is becoming addicted to their medication, nor will they be able to recognize who may be at higher risk of becoming addicted. And the other side is that at the same time, it is clear that there is inadequate training and education on the management of pain and on the utilization of prescription opioids on those in the healthcare system. So NIDA, in partnership with other institutes at the NIH and with the Pain Consortium, has been developing curriculum of both for substance use disorder and for pain that will be free and available for healthcare systems, for university, for academic centers to download and to utilize to enhance the proper training and education of medical students, nurses, dentists, pharmacists, and specialty doctors so that they are better able to provide with good care and prevent the patients from actually engaging in addictive behaviors. And with that, I would want to thank you for your attention. And I understand that the questions will be at the end of the other presentation. Thanks very much.
Well, hello, everyone. And I'm going to ask you also to advance my slide to the next slide. Thank you. So what I'm going to try to do is do cover these 4 areas. Again, talk a bit more about the scope of the epidemic, how we got here, what we can do about it, and some research and development needs that I think are relevant to this discussion as well. Next slide. Next slide. So there's about 2.5 million Americans that have a substance abuse disorder with opioids and heroin. It ultimately results in about 91 overdose deaths per day and 1,000 emergency department visits per day. So this is functionally a significant issue, both from a morbidity and mortality perspective as well as a functional perspective to the system. And as you saw before, they've risen dramatically since 1999. And this has now become the leading cause of preventable death from injury. And opioids are a major part of that injury spectrum. And the other part, of course, as you saw, is that a major gateway to heroin use. So people start on opioids and then they transition to heroin, and now we're seeing, of course, to fentanyl. Next slide. And this is another look at that same breakdown of those deaths involved in opioids, both including the synthetic opioids. Next slide. And in addition to this, the point about it now being something with more women than men, they tend to be older adults, and non-Hispanic whites are more likely to use than Hispanics, although there's no significant difference, at least yet, between non-Hispanic whites and non-Hispanic blacks. A large amount of people are in the workplace, and to the point that the companies have now recognized this as a big issue, where 7 of 10 companies now report some impact on the workplace, and at a workplace cost of about $3,000 per employee on average. So this is a significant occupational health issue as well. Next slide. And if you look at where the prescriptions are that are being prescribed, like the growth in deaths with a huge variability, you also have a variability in where the prescriptions are actually being written in our country. Next slide. So let's talk about how we got here. Next slide. So there are really just a multiple of reasons, and I think that's important because from a public health perspective, you're going to fix it. You have to recognize that there are multiple issues that have resulted in us getting here. Number one, a decision many years ago in the late 90s that we would look at pain as a 5th vital sign. Very important clinical concept, but it resulted in a lot of policies being put in place to focus like a laser on pain. And so clinicians, of course, began prescribing more medications for pain. You had a lot of people who weren't real clear about the addictive potential of these drugs, over-marketing by pharma probably. The switch to using opioids for chronic pain, again, because folks didn't think that it had that much of an addictive potential. Lots of prescribing just in case, you had your tooth pulled, and just in case you get pain, I'm going to prescribe you some opioids. Again, because they're quote-unquote safe and effective, no real addiction problems here. But that, of course, that turned out not to be the case. And then over-prescribing the amounts, large amounts. So when 5 pills will do, giving someone 30 pills, they may have only taken the 5 pills, but the rest of those pills ended up in their medicine cabinet, and that resulted in a market for pass around, giving it to someone else in your family who might have some pain today, as well as youth and others taking it out of their parents or family members' medicine cabinets, passing it around to friends, and or selling it on the street. And then, of course, an illegal market like this often develops. And then the transition to heroin was when people stopped giving those patients the opioid, who are now addicted to the opioids. They needed to get something else, and heroin was offered, and it was relatively cheap. Next slide. And this just gives you an idea of what that secondary market in terms of people's access to the opioids looks like. A large number, again, people given by a friend or relative for free. The ones that look like they're stolen, bought because someone sold it to them, or bought by a drug dealer. Next slide. So what can we do about this? Next slide. Well, clearly we need to improve our surveillance systems, and that means surveillance systems about drug use overall and the availability of these pharmaceuticals, both the illegal and legal drug use, improving our issues around measuring morbidity and mortality. When someone dies, quite frankly, the death certificates are terrible. The reporting on this is just absolutely abysmal. We don't often know whether it was one drug involved, two drugs involved, whether those drugs were involved in other conditions. So the person died from a motor vehicle accident, but they were actually high on their medication. Quite commonly, the pharmaceutical exposure doesn't get put down as either a primary or a secondary exposure to that injury. And as I mentioned, our death certificate reporting in this country is just terrible. And so that's something we also have to improve in order to get the good data. As you know, garbage in and garbage out. Next slide. We have to figure out how to optimize access for the pharmacotherapy for pain. That means improving provider understanding of actually pain management. Pain management actually isn't taught real well in medical schools, although the schools are now beginning to look at this more and more. Certainly when I went to medical school, there wasn't a lot of discussion other than the science and biology of pain, which frankly was fairly rudimentary then, but actually teaching you how to step people up for pain therapy wasn't commonly taught. And of course, teaching folks about inappropriate prescription writing around what to write it for, the fact that chronic pain is not ideal, and amounts. And then looking at a variety of prescription guidelines. CDC and others have put out some guidelines that we need to promote more. Next slide. Doing things to reduce access to illegal opioids and address the misuse potential. That includes, as you heard earlier, training, particularly on providers, consumer and education. Again, many consumers think that these drugs are harmless and there's no risk. Reducing the availability of unused medications. Again, continue to come back with programs to remove pharmaceuticals out of our drug cabinets, and of course, not just dumping them in the environment, because that creates some other problems for us. And of course, enhancing enforcement of the illegal activities by providers, pharmacists, of law enforcement and regulatory authorities. This is not just a criminal justice enforcement issue. It involves the medical care and clinical community as well. Next slide. Looking at expanding treatment for evidence-based solutions, you just heard about the medication-assisted treatment, but also let me just point out also expanding access and use of naloxone. This is a good drug. It is a good antidote to reverse opioid overdoses. One of the challenges, of course, is that some of the synthetic opioids are very problematic, and you have to use more naloxone to actually be effective. But again, that's the reason we need more research into other medications other than naloxone. Next slide. So let's talk about some of the research and development needs broadly from a public health perspective. Next slide. And I just have one slide here, and just point out that these things, and these are things that came from basically a National Academy of Medicine, Science, Engineering, and Medicine report on opioid abuse. And it pointed out the fact for recognizing the FDA as a recommendation, you need to think a more holistic approach around opioids when they look at medications. Obviously, they look at whether it's safe and effective. That's important. But they also ought to look at the secondary population-based impact when they approve these drugs, particularly for pain. You heard already about developing more non-opioid pain medication for severe pain, developing abuse deterrent opioids, incorporating more prevention strategies into the prescribing that we talked about earlier, and develop more medications for medication-assisted treatment, and then finally developing more therapies overall for opioid overdose. With that, I'll stop and I'll pass it on to our Dr. Bratberg.
Thank you, Dr. Benjamin and Dr. Volkow. It's an honor to be here. See if I can advance my slides here. Happy Pharmacists Month and happy National Substance Use Disorder Month. I'll start off with a few messages about AACT. Our motto is on the bottom of the slides here. Pharmacists help people live healthier, better lives, and we definitely, with the opioid epidemic, need an all-hands-on-deck approach here. We have 142 member schools and colleges of pharmacy, and we focus not only on the pharmacist you may know who counsels you on the safety of medications, but also perform research and essential service. We have 6,500 faculty or more, and we teach more than 63,000 students. So it's a pretty good workforce to do some of these activities we're talking about. And the mission of AACT is to advance education, research, scholarship, practice, and service in partnership with members and stakeholders like the groups that my colleagues represent, and again, to improve health for all and reduce disparities of health for all. So what do pharmacists do? We are really central providers of harm reduction. Again, as we saw in the graph, fentanyl is an immense killer here in Rhode Island and New England and over many, many places in the United States. So what do pharmacists do for people who are injecting opioids? We provide syringes, non-prescription syringes and supplies. That's been proven to reduce sequelae of opioid use disorders such as hepatitis C and HIV. We can do testing in pharmacies. We provide syringe disposal, and we also do supply controls as well, locking up opioids, enhancing the safety for the household where opioids are. We can provide drug disposal. Several national chains offer drug disposal boxes at the pharmacy. So Dr. Benjamin talked about, and Dr. Volkow talked about, the overprescribing of opioids. Well, policy maneuvers have been made at federal and state levels. There's still lots of opioids out there, and we need to reduce those. Some of the research that should go into pharmacist practice are things like drug testing, using fentanyl strips. Should that happen at pharmacies to enhance the safety of these medications? Supervised injection facilities will hopefully be operating in the U.S. if they are abroad, showing massive reductions in overdose death through supervised injection of self-provided medications. And even supervised observation facilities where people use drugs. Overdoses don't happen when this population, this at-risk population, is observed. So again, we're pharmacists, we're medication safety specialists. We believe in the safe and effective use of medications. And so I think we're practicing is emphasizing those non-opioid therapies that Dr. Volkow talked about, non-pharmacologic treatments, emphasizing and putting into place policies for using the lowest effective opioid dose and shortest duration. We, as pharmacists, like our colleagues in other clinical specialties, do need more education on pain, and I think we're doing that and how to use these medications. Co-prescribing naloxone, something that's happening more and more through overdose education and naloxone distribution, or OEND. And we're also screening to care. In surveys of pharmacists that we've done with our research, experts being done in several places in the country in pharmacies, but even simple referrals to care is something pharmacists really want to do. Opioid use disorder is just one of many disease states that pharmacists manage, like diabetes or hypertension. And we're experts in communicating with patients and providers to find out when do they want to access help and provide that help for them. Pharmacists can stock and dispense, and in some places even administer, drugs like naltrexone and buprenorphine with or without naloxone. We look forward to those new forms of long-acting buprenorphine that, if only 90% of people are getting treatment for opioid use disorders, pharmacists should absolutely be considered as a provider to expand that access, as we are located within 5 miles of every citizen in the United States. We're there at that spectrum of care. We're there in the hospital providing naloxone and overdose education and opioid safety education to patients as they leave the hospital, at those care transitions when they come to the community pharmacy. We're actually in the clinic at that point of prescribing. So we extend and advertise our immense practice load in academic pharmacy by participating in special interest groups in our associations, government task forces, county overdose prevention resources, providing that pharmacy perspective, working with health departments and hospital teams, writing protocols for appropriate length and dosages of opioids. I think what we're really doing in service, and I really highlight my colleagues in academic pharmacy and other pharmacy organizations, is family education, teen education, provider education, community education, really participating as getting out in the community and educating pharmacists too. We're there to remove those barriers to access for at-risk, disadvantaged populations who really need the treatment this most and need the full set of services. In terms of education, we need to enhance, and we are enhancing, the reduction of treatment stigma and the disease of addiction, the stigma of the disease of addiction. We're not going to expand treatment until we train our student pharmacists, our preceptors, and our faculty to train others to reduce that stigma. We need to think about supply solutions, but I think we need to balance supply and demand solutions, such as syringe provision, treatment enhancement, things that we've heard. And we need to do it with our colleagues. I think we've set, our colleagues have set in medicine, have established great competencies for interprofessional education, and we've published here in Rhode Island some papers on how pharmacists, social workers, physical therapists, nurses, et cetera, and physicians and their students can all work together, both in practice and education, to achieve those competencies. And this is not just happening in classrooms and in case studies, but it's happening in all the sites that pharmacists go. 63,000 students going out to homeless shelters, to syringe service programs, to syringe exchange programs. I would emphasize that when those the supervised injection facilities open, pharmacists will be there to help care for the medication needs of those people. And reducing disparities via a public health approach. We're the leaders. We're promoting advocacy. We're writing policy statements. This is what we're doing with our students. We're developing new medications. NIDA is funding several colleagues who are doing new medications into pain that don't have the constipation or the euphoric effects. Obviously, new drugs to treat opioid use disorder, new formulations, to new formulations of overdose response medications like naloxone. And we're examining prescribing behaviors. Why do we still have a 300% increase in opioid prescribing even though we've seen a downturn? Why do we see year-over-year increases in co-prescribing of dangerous combinations of opioids and benzodiazepines? a big data approach is what's being implemented at URI and other pharmacy schools and other pharmacy faculty to examine the prescribing behaviors of those dangerous combinations. Who's co-prescribing naloxone? Who's prescribing buprenorphine? What are those factors? How can we use that to enhance our service and practice? Who's prescribing and administering naltrexone? We're looking at, if we're providing this education, how is it being retained? If we're providing destigmatizing education, how is that being applied? What are those best practices? We're in this phase of the response to the epidemic where we've done lots of policy changes. We're enhancing and ramping up our education and our research, but now we need to study the implementation. What's the cost of all of these interventions? Is it cost effective to co-prescribe naloxone with every opioid? That's something that we're investigating. And we develop these new medications. Maybe we can tailor those medications. There's an immense effort, well-researched, well-funded in pharmacy, in collaboration with other colleagues, bench scientists and medical scientists, to look at the pharmacogenomics of pain. We knew that we need to educate people earlier and earlier about the epidemic and about these medications. So providing OUD education delivery in secondary schools is something we're doing in Rhode Island and in many other states in the country through pharmacists and others. We're detailing pharmacists. This works to talk about new drugs from pharmaceutical companies, but we found great success in actually going and talking to pharmacists about how they can help their community, how they can educate their patients taking opioids or dangerous combinations of opioids, or their patients who buy syringes from the stores to educate them about the efficacy of naloxone. We know we see a 50% reduction in overdose deaths in communities that have enhanced naloxone distribution, whether through pharmacies or community groups. We're looking at pharmacists managed buprenorphine through a NIDA grant sponsored by the Cures Act. This is a fascinating way to extend. We recently extended training to physician assistants and nurse practitioners through collaborative practice agreements. Pharmacists could also help manage buprenorphine and naltrexone and other forms. And really, we're looking back to that, how do we enhance our motivational interviewing style so that people feel that the stigma is not being applied by whether it's pharmacists or other clinicians or society? How do we screen for risks? How do we refer them? How do we recommend naloxone? And how do we disseminate those results? And that's it.
Thank you all very much for that discussion. So now we will open up to questions from our audience, and you are able to write in your questions in the questions pane of the control panel. And so we'll jump right in. Our first question is, why is this problem really only being observed in the US? What's unique here, and what lessons can we learn from other countries? So any of our panelists can jump in on that one.
Yeah, it's not unique to the United States. The United States has the highest rates of overdose fatalities from opioids, but Canada is also experiencing a very significant increase in overdose from opioids. And in parallel to what we're observing, they observed, yes, increases with prescription opioids, but they're also seeing a significant number of overdose deaths now occurring from fentanyl. And in some of the countries in Europe, this also has started to emerge as a problem. They're starting to see increases in prevalence of opioids. Most notable are England and Denmark. And what's interesting, when you look at the patterns, you are seeing it in countries that tend to prescribe opioids at higher rates than others. For example, South America very rarely uses opioids outside the hospital or the surgical context, and thus they don't have this diversion of these drugs that leads then to the dependence and addiction of individuals. So this is what accounts for the main differences and why the situation currently is so severe in the United States, so much more than in other countries. But as I say, Canada and some of the northern European countries do have a problem with it too.
And this is George's Benjamin. In fact, the Royal Society of Public Health have a report on their website that they looked at and made some national recommendations on opioids in the United Kingdom in the last 12 months.
Great, thank you. And so we'll jump right into our next question. We are seeing other diseases rise in conjunction with opioid addiction, like hepatitis C. How do we address these associated threats?
Well, this is something that is very much in our radar because, unfortunately, we've been seeing since 2007 a very significant rise in hepatitis C in our country that is driven by injection drug use, that is predominantly driven by this opioid epidemic. And it's a very worrisome one because the numbers are going up, the incidence is going up. And even though people may dismiss it because now there are cures for hepatitis C, when you look at the cascade of care of hepatitis C in individuals that are suffering from an opioid use disorder, it's basically non-existent. That is to say, even though there are these treatments that can cure, they're not being offered to individuals that are current injection drug users. Now, what are the factors why they are not being properly treated? Number one, because first of all, these medications are very, very expensive. And number two, because it is overall, one of the recommendations is that they want to wait until you have the symptoms, which take several years to emerge before you initiate this treatment with these very expensive medications. The problem of that approach is that in all of those years, you are very effective. And if you do not cure, what you are doing is just expanding the dissemination of the epidemic. So it is a very unfortunate situation that relates on the one hand to the cost of the medications itself, and the second one to the practices of trying to avoid using them until you have the symptoms.
Yeah, and this is George. Of course, both the medical care community and the public health community have got to recognize that once someone begins moving towards injecting drugs, that it adds a whole range of other potential infectious diseases into this, including HIV, syphilis, bacterial endocarditis. So comprehensive programs to include needle exchange, educating people's sexual partners, and a whole range of other contact tracing issues have got to be done as part of this if you're really going to do a holistic public health approach to addressing this problem.
And I think it's very important to recall that one of the extended release opioids, Opana, was directly linked to hundreds of Hep C HIV cases in Scott County, Indiana, and that county's results have been predicted to occur in dozens of counties with extreme rises in Hep C, some in the double and triple digits. It's $80,000 per regimen to treat, and you can't cure Hep C and then you're prevented from transmission, but that cure has to be combined with medications for addiction treatment, or MAT, and we have to very closely look at some of our opioid therapies and see, make sure that we're using those appropriately, and in providing syringes at every single opportunity, decriminalizing them and destigmatizing the provision of syringes from pharmacies, physicians, really taking a public health approach to it.
Great, thank you very much. We're getting some really great questions from our audience. How do we reduce barriers to medication-assisted treatment, including stigma and institutional barriers?
Well, that does require different approaches depending on where you are at. And I think one of the issues that we've been working on is to try to remove the barriers that currently exist for the cover or reimbursement of medication-assisted treatment by Medicaid. And Medicaid implements how they are covered, how these treatments are covered differently by various states. And in some of the states, for example, you have to fail other treatments before they agree to pay for the medications. In some of the states, they agree to pay for the medications for 2 years, even though there's no evidence that at 2 years you will be able to stop taking them. Others will support just one medication, but not the others. And there's really no evidence that there is a justification for these type of practices. So we're actually trying to, from the science perspective, provide evidence that these type of difficulties in getting access to the treatment just actually results in much worse outcomes for the patients. And then you have the private insurances, and we're working with them to try to actually engage them in covering for access to the medications the three medications that are needed, and without any restrictions. So it is very much to show the evidence of much better outcomes and cost effectiveness associated with treatment vis-a-vis the consequences of lack of treatment, to actually use that knowledge in order to justify changes in policy, to put pressure. I think that currently with the opioid crisis, what has become evident is that we urgently need to expand medication-assisted treatment, and that does require that there are structural changes on the way that these treatments are reimbursed, as well as the other element that we need to recognize is that we need also more physicians or other individuals in the healthcare system, as was presented earlier on, that can be active participants in the dispensing of these medications and in the follow-up of the patients with an opioid use disorder.
I see two, this is Jeff Bratberg, I see two really innovative approaches that Dr. Jody Rich in Rhode Island has really pioneered, and that's every person with an OUD in a prison gets MAT. And that's despite a principal barrier, which is, as Dr. Volkow said, Medicaid is in most places the principal payer for OUD treatments. And when those limits are removed, that's a positive barrier. But the big limit is that Medicaid does not cover people when they become incarcerated. So if that barrier can be eliminated and we can start people at MAT instead of having them go through withdrawal in prison and then leave with a 500-time risk of opioid overdose, and maintain them on MAT, that's an extremely high-risk population that I think that can be successfully addressed. And of course, pharmacists could be providers of MAT if they change the regulations for that.
Thank you. And we have time for one last question. What gaps remain in research that are vital to making progress against opioid addiction?
Well, there are many gaps that remain for us to plow through, and certainly I very much highlighted right now gaps of research that can result in translation of products that could be implemented in relatively rapidly, because there's an urgency of taking care of this epidemic. Whereas I dwell much less on the area of research that will take longer time to develop, but that in the end may come up with transformative solutions to the problem. So we are doing, there's a lot of work that we need to understand, for example, in terms of vulnerability. Why do some people become addicted to drugs and others do not, and how to actually, what are the changes that can predict the loss of control in addiction? Are there changes that can predict that someone will get addicted so that we can do prevention interventions? And can we learn how to revert them? I mean, so those are some of the examples that could lead, for example, and this is a question I get asked very frequently, are there any biomarkers that could be used to determine if a patient needs an opioid medication, whether they will become addicted there or not? Are there biomarkers that can lead me to tell that a patient will respond better to this treatment versus not the others? Research on how long does a patient need to be on a medication-assisted treatment before you actually can determine that it's okay for that person to be weaned off of that particular treatment. So these are some of the examples of the areas of research. Others that are very, very relevant is in terms of where we've done much less work, and again, because of the resources we need to identify priorities, is the very high frequent comorbidity between opioid use disorders and mental illnesses, and the fact that in the United States, for example, the majority of the prescriptions, close to 50% of the prescriptions, are given to individuals with a mental illness. I mean, a mental illness which constitutes 18% of the population. So they are at much higher risk then being subjected to these opioids and then developing an opioid use disorder. So why? Why is that? What is the research behind it? We are also doing a lot of work in understanding how the human brain works. And why is that important? Because as we understand better its organization, well, then we can lead to interventions that are not based on medication, but that use stimulation strategies like electrical or magnetic to actually strengthen or inhibiting certain networks that in order to improve the resilience towards substance use disorders or to buffer some of the damage that there is there. I mean, we've done enormous advances in terms of the rehabilitation of the brain after a stroke. And my perspective is we should use that as an example in terms of our ability to be able to have a significant recovery of the brain of people that have been exposed to drugs. And so these are just some of the examples, but as I say, what we can, if we have the knowledge, then what I would hope that one day we'll be able to be in the position of saying we have a cure for drug addiction, or we have an intervention that will prevent addiction even in a person with a very high vulnerability.
Thank you very much, Dr. Volkow, and unfortunately that is all the time we have today. Thank you to our panelists for your time this afternoon, and thank you to our audience for your participation. We'll be continuing this discussion online and on our social media channels. Please feel free to visit any of the platforms on your screen right now. We will be posting slides and a recording of the webinar on our website later today. Thank you very much and have a great day.